Posterior capsular tears, which happen during phacoemulsification, need specific management for optimum outcome. And here, with the help of this video, we'll see this process. So this was one case which was to be operated for phacoemulsification for visually significant cataract, and the surgery was started, and keeping in mind the steep axis, the incision was placed at nearly horizontal meridian at 180 degrees. So this was a nuclear sclerosis kind of cataract with grade 2 to 3 nuclear sclerosis, and keeping the incision in the horizontal meridian was intended to reduce the existing 0.5 diopter of astigmatism. So this was a pretty straightforward simple phacoemulsification, and we'll just go through the steps of this process. Creating a adequate size capsular axis. These cataracts have a capsule which is neither very fragile nor very elastic. So capsular axis is a breeze. However, because of position of the incision, which is little awkward for a routine situation, it was little difficult to grasp capsule at a particular angle. However, the capsular axis was finished uneventfully. Proceeding for hydrodissection, and in these kind of immature cataracts, it's always better to do a hydrodelineation. However, I failed to define a smaller nucleus because the nucleus was large enough. In any case, proceeding for phacoemulsification, little snug fit of the phaco sleeve, and now we are proceeding for the phacoemulsification. That posterior capsular tear can happen during the process of phacoemulsification when the phaco tip is being used to disassemble the nucleus and consume it. And you can have scenarios which range from having a complete total nucleus in the bag when the PC rent occurs to a situation where just a small amount of cortex is left behind and there's a PC rent. So the process is complicated because of a posterior capsular tear, just because of presence of vitreous behind the posterior capsule, which invariably prolapses anteriorly because the nature of the procedure is such that there is constant fluid movement and turbulence created which pulls up the vitreous into the anterior chamber, and it is this vitreous which is going to cause issues later on and also during the surgery. So here we have disassembled the nucleus and removed it successfully, and there is some amount of cortex which is left behind. Now remember, the hydrodissection was not very adequate here, and that causes some amount of adhered cortex which is also inherently because of the nature of the stage of the cataract. So the safe procedure is to engage the anterior end of the lens fiber which is resting just beneath the anterior capsular axis margin, and then peeling it away from the posterior capsule. So this is how ideally the cortex is removed. However, when you have a cortical matter which is adherent to the posterior capsule, one has to reach up to it, and that makes the situation a little tricky for removal of the cortex and gaining some risk for posterior capsular tear. So we'll see here what happens, and this is the point when the tear has occurred, and I realized it little late, so I proceeded to remove the cortex elsewhere which was in easy access, but the PC rent had occurred, and now after realizing that, I shifted the paddle from aspiration mode to simple irrigation, and then the first thing to be done is to form the anterior chamber with viscoelastic so as not to allow more of the vitreous to prolapse into the anterior chamber. Once this has been done, then you gradually and very slowly remove the phaco tip, taking care that none of the vitreous fibers are pulled in the process. And this will require a management plan which will be using anterior vitrectomy. Anterior vitrectomy is very important in these scenarios because the vitreous, when mixed with the cortex, causes hindrance in the removal of the cortex, and not only that, the vitreous which is left behind in the anterior chamber is going to cause problems in coming future. And I will like my audience to post a comment about how do they manage these situations, and also particularly about communicating the incident to your patients. So one thing which I want to highlight here is that in these scenarios it's very important to have a foot switch which is dual linear. Now the important thing about dual linear foot switch is that you can independently control the irrigation aspiration process independent from the vitrectomy cutting process. And because they are both the process are linear, so you can vary the cut rate and also the vacuum independently of the vitrectomy process, so that whenever you desire you switch from cutting to aspiration. And that's very important because in these scenarios you do want to cut the vitreous, but at the same time you want to retain the capsule as much as possible. So when cutting vitreous you are in vitrectomy mode, and when switching to aspirating the cortex you switch from cutting mode to aspiration mode. And that's very important, and I always tell my students to go for a phaco machine which has a dual linear foot switch instead of having a single linear foot switch. It's very convenient and very protective for not sacrificing the remaining capsule if you have a dual linear foot switch. The purpose of this anterior vitrectomy is to remove as much vitreous from the anterior chamber as possible, and still to retain the anterior capsule and the posterior capsule, so that one has adequate support for implantation of a posterior chamber IOL either in the bag or in the sulcus. Now here we have a small defect in the posterior capsule, but it is not very large and majority of the posterior capsule is intact. So we will plan implantation of a posterior chamber intraocular lens. So this is a monofocal hydrophobic single piece IOL. It's a preloaded design, and here I am implanting it with the wound assisted technique. And when the IOL starts coming out, we can see that the cartridge is being repulsed out. That is because of the technique itself. And once the IOL has gone into the bag, the leading haptic has gone into the bag, you dial the trailing haptic into position. Usually any vitreous strand, if it is there, will usually cause displacement of the IOL and will be a hindrance in the proper centering of the IOL. And this is something which should be recognized and will be a very sensitive sign for deciding that there is a vitreous strand which is straddling from the posterior capsular tear up to the wound. So sweeping underneath the primary incision just to see if there is any vitreous which is entangled. One can also use triamcinolone to stain this anterior chamber vitreous, and the vitreous will be shown by the opaque triamcinolone which adheres to the vitreous strands. Now putting pilocarpine will do the same job. It will show you whatever tractional elements are present which are bridging from the posterior chamber up to the wound. Here I could see that there was a pupillary peaking once the pupil was constricted using a pilocarpine, and this is a sure sign that there is a vitreous strand. But the strategy to cut the vitreous from inside didn't work, so I switched my hands, and now so you engage the vitreous strand using a blunt instrument, a dialer which will hook the vitreous strand, and once you have hooked the vitreous strand, it will be seen by its appearance and also distortion of the pupil. The moment the vitreous strand is trimmed away, the pupil gets round and the vitreous is reposited back. And that's a very assuring sign that we have removed any amount of vitreous which was present there in the wound. So at the end of this procedure, we have left behind some amount of cortex, but it should not matter because it's a very small amount. Now my question here for the audience is, how do you interact with your patient once you have had a PC rent? Do you still communicate even if there are no symptoms and the visual recovery is excellent or not? This is the day 1 post-op picture. The patient has excellent outcome. The vision is 6/9 BCVA. The IOL is well centered and there is no pupillary peaking as visible on this photograph. Thank you.